So, Rob, we are at 1. Shall I wait a little bit longer or shall we begin?
I think we can crack on. We might get a few more people join, but yeah, fire away.
Okay. So, welcome to everybody this afternoon. Welcome to DCHS's annual members meeting. This is not my first meeting as being part of DCHS, but it is the first one that I have the privilege of being chair, both of today, but being chair of DCHS. Dom, if I could just have my first slide. I think you might hear Dom's name quite a lot this afternoon, and just the next one, thanks. So I'd like to say a very big thank you to everybody for joining us here this afternoon on behalf of the board, both Tracy and her executive team, but also our non-executive colleagues that are able to be with us this afternoon as well. We decided to meet virtually again this year as it makes much more sense in terms of accessibility given the wide geography that we cover here in DCHS. On again, please, Dom. This afternoon, we're going to have a session of two halves. In part one, colleagues will be celebrating just some of our achievements in each of the priority areas of our organisational strategy, with a big focus on quality improvement. There will be time for questions at the end of those presentations. Some of those, as you could see in the opening slide, you can ask questions or they can be put in the chat. They will be picked up and I will chair that question and answer session. And then there'll be a short break for 10 minutes and then we'll go into perhaps what is the more formal part of the afternoon with a review of performance from Tracy and her executive colleagues and a lead governor presentation from Lynn Walshaw. The purpose of that second session is for you to be able to hold us to account. And again, at the end of that, Tracy will actually chair us a question and answer session. But before we hand over and go into the presentation part of this afternoon, I'd just like you to indulge me for a few moments to have the opportunity to reflect on my early months of being chair of DCHS. So since becoming chair, I've visited a number of teams and seen firsthand the incredible things that we achieve and that you do every single day. This visiting is a very important part of my role, but it's also a very enjoyable one. And I've got a very busy diary going forward as well. And I'd like to say thank you to Catherine, who helps me organise that. I don't know what I'd do without her. I do say thank you in my chair's reports to everybody that we've visited, or I try to, but to just name a few of the places that I've been this year. So I've been to see the Wound Care Service, St Lawrence Road GP Surgery, Oak Oval Ward at St Oswald's in Ashbourne, MSK and OT teams at Ilkeston, a number of quality gold panels, which are always an absolute pleasure to be part of. The Dementia Palliative Care team, who we'll hear from this afternoon, patient experience team and our volunteers, and also our diabetes education team, where I think I actually asked far too many questions. I do apologise for that again. I received the NHS 75 baton at Ilkeston Hospital, which was just great to be part of as part of the NHS 75 celebrations. And I was lucky enough to welcome the Duke and Duchess of Devonshire with Tracy and our brilliant Matlock Hospitals League of Friends to open the new Community Diagnostics Centre at Darley-Dales Whitworth Hospital. Early next week, I'm really pleased to say that I'll be taking my fellow chairs from the system around the UTC and the CDC again. We signed the Armed Forces Covenant, and I also had the pleasure of opening our inclusion conference and hearing some powerful accounts of people's experiences of working within DCHS, which wasn't always easy to listen to. It is one of our values as a trust to value diversity and inclusivity. And this demonstrates the importance and value we place on diversity and inclusion. Although we really recognised at the conference that we've still got plenty of work to do and it's one of a clear priority for us. We do work closely with our 4 staff networks who are involved in our governance and decision making, and really grateful for your input to that. Another one of our values is to act with compassion and respect. And that's why, again, I was really proud to be working with Derbyshire Constabulary's Chief Constable Rachel Swan on a new zero acceptance campaign, which is designed to give a clear message to everyone in health service settings that any antisocial, abusive or aggressive language or behaviour is just unacceptable. It would be remiss of me not to say this afternoon that I wanting to highlight the importance we place on our speaking up culture, empowering and encourage all our colleagues to speak up and raise any concerns they may have about clinical quality or patient safety. We've seen shockwaves throughout the NHS and the whole country over the past month following the conclusion of the Lucy Letby trial in Cheshire. It really was truly heartbreaking series of events and the unthinkable consequences for everybody involved. Many of the media reports have focused on staff not being able to speak up and suggestions that doctors were prevented from doing so. These issues will be fully addressed in an inquiry announced by the government, but we as a board took immediate action through our executive team to write to all staff, reminding them how to speak up, and I would say that again today. These events have had a profound effect on us, so we also reminded staff, and we need to do this on a continuing basis, of the support available if you want to talk to somebody as part of our wellbeing offer. I can really proudly say, as being part of DCHS for so long, that we've always tried to nurture an open, honest and supportive culture where colleagues are encouraged and empowered to raise concerns about clinical quality or safety without any fear of recrimination. And we're really going to drive that message home over the coming months, particularly with the National Speak Up Month, which is just around the corner. Michelle, I got that wrong. It's October, not September. The theme for this year is breaking barriers and how we must remove any barriers that can stop staff from speaking up. And I'm going to just leave it there, say a very big thank you. It's been an absolute delight to be the chair for the last few months. And we're going to move into our presentation. So Dom, it's your name again. This afternoon, the projects that we've chosen are presented in the context of our new 5-year, it's the one before, sorry, that's great. Our new 5-year organisational strategy. If it matters to you, it matters to us. The strategy has been developed after months of engagement, and success will be measured by the difference that we make to people's lives. The next one, Dom, you were a bit previous there, but this is great. The one after. Never mind, Dom. The other context for our presentation is the lens of quality improvement and thinking differently to explore creative solutions. And on this slide, which I hope many of you have already seen or will continue to see, are our 8 QI principles. I won't go through those because I think they're quite clearly displayed on that figure of 8. And with this in mind, I'm now going to hand over to Rebecca Spencer, General Manager, who's going to take us through a great example of working in partnership around sexual health. Hi, Rebecca.
Hi, Julie, thank you. So just to quickly introduce myself, my name's Rebecca Spencer and I'm the General Manager for the Integrated Sexual Health Service delivered by DCHS. Sexual health services play a vital role in promoting sexual health and well-being and preventing the spread of sexually transmitted infections. The services we deliver here at DCHS encompass STI testing, but also a wide range of contraception offers, and PrEP, which helps to prevent HIV transmission, counselling and support, sexual health education, online services, community outreach, screening programs, vasectomy, and HIV treatment and care. We also work with a significant number of community partners who DCHS subcontracts to deliver services on our behalf, particularly where this supports where this supports access to vulnerable population groups or removes inequitable access, such as in rural communities. I really hope you enjoy the presentation and hearing about the valuable work that's been done by the sexual health team over the last year in terms of quality improvement. Thank you, Rob.
Welcome to our presentation around working in partnerships and quality improvement with integrated sexual health services. Within ISH, our model of work is working in a layered way for a full system approach. This means working with the person around their individual needs, moving on to working with partner agencies and how they can support people's sexual health, right the way up to specialist interventions and what we provide in our clinical settings. Prevention and self-care at a universal level is important to us in sexual health. Partnership working is key to this. We work very closely with our partners in the voluntary sector. This meets the need of local community members and it's delivered by a person that they trust in a place that they feel comfortable. We do this because it allows better engagement for our people and access to sexual health services that might not have happened if they weren't working with that voluntary sector organisation. We also offer condom provision across all ages within Derby and Derbyshire in a range of venues and a range of ways to support the person to self-care.
Hello, my name is Ryan, Manager and Sexual Health Champion at Derbyshire LGBT+. Our sexual health contract allows us to target some of the highest risk communities in Derbyshire and Derby City. We can deliver sexual health awareness and education sessions in a way that is accessible to our community and in a way that makes sense to them. We are now also an offline kit distributor, which means we can distribute SH24 screening kits directly and immediately to our community. And this means we're reaching people that might otherwise never engage with service. This really has been a huge development for us. This service, along with our targeted education and awareness programme for PrEP, will hopefully have a lasting and tangible effect on the sexual health of the LGBT+ community in Derbyshire and Derby City.
Sexual health promotion are a key function within integrated sexual health services. They provide community-based sexual health interventions, which include education, sexual health testing, and condoms. The team work to target communities who might find it more difficult to access generic sexual health clinical services. This might be due to the geographical place where they live, it might be through lifestyle, it might be through having some misconception of stigma around attending sexual health services. The team deliver a range of techniques. They work out and provide educational workshops. They go out and work within local community venues so that they are most accessible to a range of people. As we can see, we have our sexual health promotion bus. This is one of the ways that we were able to go out into local communities and think about how we can improve the quality of our service. This enables us to get to locations that generic clinics can't set up and pop up. It allows people to come along and see us in a range of places across Derby and Derbyshire where people might not have seen sexual health services before. We also have specific roles within the sexual health promotion team to work with communities to encourage better engagement within our services. For example, we have an ethnically diverse communities worker who works within communities from diverse backgrounds across the county and city in safe spaces for them. This project enables people to access sexual health care in a place that they feel safe who wouldn't otherwise access sexual health care.
We run 4 sexual health campaigns each year. Campaigns like the current PrEP one are evaluated and reviewed with improvement in mind to make sure we're reaching the right people at the right place to receive the information they need to make informed decisions around their sexual health.
Action Funding is a grant-based project set up by Sexual Health to support smaller grassroots organisations to access small pots of funding for a project within their community to improve knowledge and awareness of sexual health services. Within Sexual Health, we support the application process and the project itself. And at the beginning of the project, we train workers in basic sexual health awareness. Within the last year, we've had 14 projects that were successful, working in a range of creative and innovative ways to engage people that may not have accessed mainstream sexual health services before and therefore might not have encountered our messaging. Partnerships and co-production are so important within sexual health. Sharing these messages through local people telling that story has enabled better quality delivery to engage and connect with community members much easier in front of them, meaning the messaging is better received. Sexual health networking events are another way that we bring professionals together. It allows people to have a shared understanding around sexual health messaging and learning together. They can then take these messages back to their workplaces and a ripple effect of learning can occur. Working with GP and pharmacy partners allows sexual healthcare to be accessed in many more locations. It also allows patient choice to access where they would like to in a range of places and providers. We work with the partners to train and support them to make sure that the quality of care is of a high standard whichever place the patient attends. Within our clinical sexual health services, we have seen quality improvements over the last year. These are some of the ways that we have been delivering this: through improvements in results, partnering with the primary care network to provide a sexual health clinic on our behalf, taking on the lead provider role with vasectomy services and HIV services in the north, and contributing to the national agenda. These interventions are allowing us to search for improved service delivery, efficiencies, and reducing stigma in sexual health.
Hi, I'm Vicky, I'm the Senior Health Advisor for the service. We've improved our results process by working collaboratively with the laboratories, looking at reducing the turnaround time. We've been able to reduce our notification times to patients by making changes to our process. Staff are all on board with this as the new process includes some automation, therefore freeing them up for more complex patient work.
Being a lead provider within the system, we play a key role in moving the sexual health agenda forward. However, we are invested in making sure sexual health improvement is a system approach, and only by having a shared collaboration we can truly move this agenda forwards. Over the last year, we have used different methods to achieve some of this. The sexual health needs assessment, making sure we had a local community engagement assessment to hear local people's voice. Sexual Health Action Research Project, the SHARP project, was a research project within the community to hear from our patients who currently access our service, from our staff, and also from non-patients, people who don't already access our service, so we could really hear how we could improve our service accessibility. We also work within the Sexual Health Alliance. This is a strategic partnership group to decision make around shared system approach for the sexual health agenda within Derby and Derbyshire. So what does this all mean? This gives us a longer term vision, planning and impact to improve the Derbyshire and Derby sexual health system. What's next for us in integrated sexual health? Well, based on the research and data that we've completed over the last year, we will be refreshing our sexual health strategy. We have an electronic patient record, allowing patients to make their own bookings and be in control of their own information, allowing the service to be more accessible to them. We're trialling some in-house lab testing facilities. And finally, we're hoping to introduce the IQ PAM. This is a service improvement tool which allows us to look at data in a variety of different ways, for example, at patients' ages, ethnicity or disability status, enabling us to monitor who is attending our settings and showcase to us any gaps to look for areas of improvement.
Thank you.
Thanks very much, Rebecca. It was remiss of me not to say that Sexual Health Services was one of the early visits that I did. Is everything okay?
Yeah, I was laughing because I was going to remind you, but then I thought I wouldn't.
Yeah. No, that's absolutely fine. I thought you were upset then. Sorry, but it was one of the very earliest visits that I had, and I was there for a long time, if you remember. And then I failed to actually be able to attend the Sexual Health Alliance, which I apologise for, but we'll get there. But I think what you've given us there was just some fantastic examples of the partnerships, but it was the partnerships and the co-production that have really made the difference. And in that respect, it's a massive thank you. I thoroughly enjoyed my time there, which is fully expressed in the presentation that you've given. But I will get there, I promise. Thank you very much. We will we'll have opportunities to ask questions later, but now I'm going to hand over to Pippa Martin, who's the Service Development Lead, and we're going to talk about the next theme of the organisational strategy, which is around healthy communities, and you're going to show us a project there. Hi, Pippa.
Hi, thanks very much, Julie. Good afternoon, everybody. Thank you in Derbyshire, and I'd just like to start by saying that I'm here to represent a fantastic team that's been working on this project. Although I'm the one sharing with you today, it wouldn't have been possible without them. For those of you that might not be aware, health visitors are specialist community public health nurses. This means they're registered nurses or midwives with additional specialist training that equips them to support children and families in the early years of life, which is crucial for health and well-being throughout the rest of life. I'm here to talk to you today about how we've been engaging with parents and carers to develop health visiting clinics. Historically, health visiting clinics have been offered for many years in Derbyshire to make the service easily accessible in local communities and support families with questions or worries about their child's health or development. Clinics were run at fixed days and times, and families could turn up, no appointment needed, to see a health visitor. Of course, this wasn't possible during COVID, and so since 2021, health visiting clinics have all been available by pre-booked appointment only. However, we're aware that a lot has changed in the health service in recent years, and that there's a real lack of evidence base for health visiting clinics. So how do we know whether they make a difference for children and families? If they do, what is that difference? And how can we use the health visiting capacity that we have most effectively? One element that we felt was really important for us to be able to answer these questions was to hear the voice and opinions of families in Derbyshire about what they wanted from clinics. We knew this would be essential to us delivering a service that effectively supports and empowers families to give their children the best start in life. So let's look at how we did this and what we found. Our clinic project team, which included clinicians and leaders from the service, worked with the Improvement, Innovation and Effectiveness team in DCHS to develop a service user engagement survey. This was supported by the questionnaire panel, who helped us to make sure that our questions would provide us with the information we needed and would be easy to understand for parents and carers. Our fantastic admin manager, Kirsty, sent this questionnaire to parents and carers of around 15,000 children in Derbyshire who are under 5 and who are under the care of the health visiting service. We received 1,306 responses from families, which represented a total of 1,627 children. These responses gave us a huge amount of quantitative data for analysis, which we were delighted about. And in addition, 260 of these families also gave further qualitative feedback, which added more depth to our understanding. So as you can see from the graph on here, families told us that the top 3 reasons why they would go to a health visiting clinic were for advice about their child's development, to check their child's weight or growth, and for support for their own worries. The quantitative data also showed that families seemed to have a preference for booked appointments rather than dropping clinics. However, our analysis of the qualitative data showed that many families felt they would have liked more support with common public health topics such as sleep and feeding their baby or child. But families often reported that it was difficult to make a clinic appointment, or that they felt their question wasn't important enough to take up an appointment. Some parents remembered dropping clinics and commented that these were a really useful way to access support for their queries or to connect with other parents. We've been able to see from our findings that being able to access the health visiting service when questions or worries arise is really important to families, and that they appear to value both pre-booked and drop-in clinics when they need a face-to-face contact, because they recognise the different benefits that these approaches bring. So what are we doing about it? Next slide, please, Dom. Since undertaking this survey in January 2023, we've used the findings to further develop our project. In July and August, we attended a sample of clinics across the county to hear more families' stories. We've also developed a separate questionnaire to use with some of our more vulnerable families when we visit them at home, as we'd identified that they were likely to be underrepresented in our findings so far. We've also used our findings to plan and implement some pilot projects. We recognise that communities across Derbyshire vary a lot. For example, in a market town, many families might have access to public transport and might drop into a clinic because they're in a town centre anyway. In contrast, in some rural areas, a family might need to travel for 30 minutes to access local health services. So we've asked our local teams, using the findings from the parent and carer feedback, what's one change you could make to clinics in your area to improve access to health visiting? And local teams are piloting local responses. As with all NHS services, we need to manage demand and capacity carefully and ensure we don't overload our workforce by adding or changing too much at once. But so far, our pilots include pilots happening in Amber Valley. This allows families to book a clinic appointment online for a 3 to 4 month review, which hopefully makes clinic appointments more accessible for these families. In Bolsover, the health visiting team are piloting a group for parents of babies aged 3 to 4 months old, where they can find out about introducing solid foods from 6 months and also check their child's growth if they would like to. And in North East Derbyshire, 2 teams are piloting drop-in clinics, and these are just in the process of getting started. The plan is to collect further feedback from parents and carers in all of these pilots and review this after 3 to 6 months to further refine and develop how health visiting clinics are offered in Derbyshire. It's our hope that this project will help us to shape services that are accessible and relevant to local families. Listening to what families want and need has been a key part of achieving this aim. Thanks very much.
Thanks very much, Pippa. That's great. Again, it's so important. There's a theme there, isn't there? The importance of engagement and co-production, and that success is actually built on listening to local communities. So great. Thank you very much. For our focus on the future, I think we have a video from Lisa Sultan talking about from our speech and language therapy and stroke and neuro services. I think we're straight into a video. Yeah.
Hello, I'm Lisa Sultan. I'm a speech and language therapist and general manager for speech and language therapy and stroke neuro services in DCHS. I'm wanting to share with you some work today that we've been doing in the speech and language therapy service to deliver an improved experience for children and adults who stammer, with a real emphasis on a future forward focus and how we've used virtual delivery to make a difference to patient care. I want to give full credit and acknowledgement to my colleagues who deliver the service, particularly Natasha Wimbledon, the clinical lead, and Laura Haynes, one of our specialist speech and language therapists, for the work that they've been doing on what I'm about to share with you. So the issue we were trying to tackle was very much post-COVID, the length of waits that we had for initial assessments that were causing concerns for patients and the clinical staff who deliver the service. For people who stammer who were in our adult service, they were waiting up to a year to be seen for initial assessment, and children were waiting up to 6 months. Both of these waits were completely unacceptable in terms of well-being, prevention of more long-term impacts, especially for children. We recognised we had a finite resource in the service in terms of specialist skills and the capacity to expand this amongst other competing priorities. We very much wanted to take an empowerment-based approach to enable the right people with the knowledge and the right skills to make changes in how we delivered the service. And this is what Tash, Laura and their colleagues have done. So we wanted to focus on using the resource available to have the maximum impact using their specialist skills in the most effective way. And we moved towards trialling an offer of a virtual workshop for new referrals. Adults were offered an MS Teams workshop, a one-off. Families of young children were offered 2 sessions of workshops, also on MS Teams. We tend to get 2 to 3 adults who attend the adult workshops and 5 to 10 families attending the workshops for children. This does vary. The workshops we offer provide information, self-management strategies, advice and support. And following the workshop, there could be an option of opting into further one-to-one follow-up. However, we found that 60% of the adult stammerers felt they didn't need any further input from us following the workshop. So I want to share a clip of one of the family workshops we've done recently to share a flavour of how they are run.
We thought we'd just open up a discussion really about how you're responding to moments of stammering in your children. Do you talk about it as families or not? How you feel about that?
So similarly, we try and give him time and space without raising our eyebrows or widening our eyes or you know, having some sort of reaction like that to it. And also try and get rid of any distractions that we think are going on. So like if the TV's on or something, because he'll be half looking at that and trying to get his words out. So we're like, okay, I'm just going to turn this off for a minute while we finish talking. And that seems to really help because it brings his concentration back to what he's trying to get out. I was worried about not acknowledging it as well and turning it into a big thing. And I just wondered maybe if we didn't acknowledge it, but give him the space to work through it, that might.
The feedback that we've had has been really positive. We've had 100% satisfaction from both groups. For the families, it helped providing them with knowledge, connections with other families and accessing support, and generally an overall feeling of it being a positive experience, enabling the parents to feel empowered to support their children effectively and also to reassure them, which is really important as a parent when you're trying to support your child with their difficulties. And for the adult workshop, again, we've received really positive feedback about expanding their knowledge and their understanding of their dysfluency. The recognition that they weren't the only one struggling by having contact with peers. They were able to get information from an SLT that helped them feel more empowered and more positive about living with their dysfluency. But don't just take my word for it. Here's another video clip of a parent who attended a workshop recently, explaining the benefits to the session she attended.
What have I learned or what was most useful? Not you're fine, just saying, yep, we're listening, that's good. So I'm going to try and take that away and use that a lot. Because, as somebody else said, we thought we were helping by just saying, yeah, it's fine, slow down, you're good. But, yeah, it's drawing attention to it in a negative way almost, so I'm going to try and do that. And I genuinely don't think there's really anything that could be done to improve upon it, because you share the screen with the presentation. Always what you want to hear, isn't it? But you share the presentation as you go. You've shared all of these links as we went. I've copied and pasted those links, so I've got them for later, so that I can, again, show my husband all the different things that we've done and do that. Especially the videos that you were going to show us anyway, you put the links in there so that I can come back to them later. That's so helpful. And I know that you're sending out the facts as well, but having the separate links so I can go to it and go, okay, these are the links I can go through. Fantastic. I love that. It's really helpful for moving forward.
So thinking about the future and what we're going to do going forwards, this approach has now been established as our baseline core offer for people who stammer. Our waiting times have been massively reduced. All our adult referrals are seen within 13 weeks and all the families are offered a workshop within 8 weeks. This has enabled a reduction in the pressure on mainstream caseloads and it's released capacity elsewhere in the service, which is really important, especially in the children's speech and language therapy service, where post-COVID demand remains very high and our waits are still much longer than acceptable. It's enabled us to provide early support to children and families and helps to reduce longer-term issues with disfluency becoming embedded, and provided timely support to adults to help reduce mental health impacts and the social implications of stammering. We're really focusing now on ensuring that we use learning from this area of the service to other parts where virtual workshops could also be used more consistently. We think this is a great example of frontline clinicians taking action to resolve a long-standing issue and feeling empowered to work differently and think about moving forwards into the future to make a positive impact and make a change to how we deliver the service. Thank you.
Thanks to Lisa and the team. I think those workshops really show how the support leads to improved experiences both for children and for adults. And finally, in this part of our agenda, going to introduce Gemma de Toro, going to be speaking about her dementia palliative care team. Welcome.
Thank you. And as part of this presentation, we also have Tim joining to present, who will be sharing his story with us shortly. But as you may or may not know, the numbers of people diagnosed with dementia are rising and rising significantly. Currently in Derbyshire and Derby City, in the advanced stages, so possibly likely to be in the last year of life, we currently have around 9,500 people, like I said, living in advanced stages. And 1 in 3 people will possibly develop dementia. So the numbers and the care and support needed is growing significantly. Next slide, please, Dom. So we were having a conversation, this was all pre-COVID. We knew it had become apparent over a period of years, driven by increasing comorbidity of people living with dementia and supported by evidence locally and the national direction, that actually approaches for people with dementia who had palliative care needs and who required end-of-life support were actually lacking, and that a significant and unacceptable gap existed in the care for people living and dying with dementia. The National Well Pathway for Dementia itself had actually an element of dying well, that people living with dementia die with dignity in a place of their choosing. But prior to our work, actually little steps had been done to address this within current models and service delivery. So back in March 2020, like I said, we've been having conversations, we've been starting to look at what we could do within Derbyshire. And COVID actually brought about an opportunity because tape was lowered, loops to jump through were slightly less, and we actually created a service. We created part of our vision that we'd been looking at, and that was the Derbyshire Dementia Palliative Care Team. The aim of the service is to enable improved palliative care for people living with advanced dementia, quite often with multiple comorbidities, supporting them within care homes, supported living, or within their own homes. And the service is focused on ensuring that people remain at home where they want to be, wherever home may be, and avoiding admissions where that is appropriate into acute care. We wanted to close the gap in that pathway and making sure people had their palliative and end-of-life care needs met. We wanted to reduce the system impact, look at reducing length of stay when people are admitted into hospital. We wanted to reduce inappropriate referrals, number of bed days, readmission rates, etc. We wanted to improve the dementia pathway and particularly the dying well element, both through clinical quality and equity. We wanted to support care home staff as well, particularly supporting palliative care needs, and in particular because we were starting this service right at the start of the pandemic, so we knew there would be great need. We wanted to improve training and education. We wanted to ensure mainstream services had more awareness. We wanted the community to have more awareness of palliative care needs for people living with dementia. And we wanted to do all this based on national guidance and best evidence-based practice. So this, like I said, this was a service that began. Originally, it was myself running around Derbyshire with 3 shielding staff from Derbyshire, the Dementia Rapid Response Team, sorry, and very quickly we proved need, we proved the value, we proved the impact, and since then we've grown and grown significantly and continue to grow. So we now have myself leading the service, we have a Band 7 senior nurse, we have consultant in palliative medicine input, we have consultant psychiatry input, we have training input, we have Admiral nurses that are funded by Dementia UK, and we have a whole team of Band 6 nurses and Band 4 and Band 3 assistants, just absolutely doing a valuable job supporting people living with dying with dementia across Derbyshire. They all carry a caseload and work together to make sure people's needs and families are supported. When it first set out the service, we thought we'd probably get about 40 referrals a month. That's what the ICB had predicted. We're currently on around 120. At any one time, the service is supporting around 500 patients across Derbyshire and Derby City. We have different response times to make sure we are meeting their needs promptly, particularly to avoid admissions into hospital where we can, because we do have a direct referral pathway with East Midlands Ambulance Service. Paramedics can refer to us when they're on scene with a patient and family at home, and hopefully avoid that conveyance to hospital by referring to us, and we go out and respond urgently. And then we have other response timeframes to support people's palliative needs, and we also support a lot of people's anticipatory care, so having those early conversations, getting advanced care plans in place, because those can make a significant difference when moving into the future. We do support a lot of discharge from hospitals and to reduce length of stay from hospital as well. And we get referrals from everywhere. It was really important to be an open referral service, so families didn't feel they were in a black hole and didn't know where to turn, because that was feedback I'd gotten previously. They can pick up the phone and make that referral. But we get referrals from professionals all across the system, from acute services to GPs to our district nursing services and colleagues within DCHS. We also have direct referral pathways with our colleagues within older adults community mental health teams and within dementia rapid response teams as well. Just to share a very quick case example of what difference it can make, what difference it can make to the person and family, but also what difference it makes to the system. A lady I supported quite early on, Mrs. B. She was diagnosed with Alzheimer's. She was in advanced stages of dementia. She had a history of breast cancer, and it was likely there was a probably underlying recurrence. District nurses had been in, community mental health teams had been in, dementia rapid response, and she was on the GP palliative register. She was referred to us because husband was really struggling and didn't know where to turn. He'd contacted out of our services, ambulance services, GP services, 111, 29 times in a 4-week period because he didn't know where to turn to get the help and support. We went in, we did a whole holistic assessment. She actually had quite a bit of unmanaged pain that hadn't been recognised. We instigated fast track to get more care support. We did lots of support visits and built relationships with both Mrs. B and her husband. And we identified his needs as carer as well. After that, we supported her to remain at home where she'd lived with her husband and family for 53 years. And her quote from her husband said, "It helped me fulfil my wife's wish of remaining in the house where we had lived for the past 53 years for as long as possible." And she died at home with a family around her. And that's just a quick example, as you can see, but a significant, because that is multiplied hundreds of times by all the patients and families we've supported. But somebody to share their story better than I can, I'll introduce you to Tim. And I'll let him share his story along with his wife, Winnie.
Hi, Gemma. Thank you for the invite. First of all, as somebody who's outside the NHS and a recipient of the service, if you like, I find it heartwarming to have the opportunity to be involved in events like this and see the great work that's going on behind the scenes in providing support. So thank you for that. So I'd like to share a little bit about my wife's story. Winnie was diagnosed with early onset Alzheimer's disease 14 years ago, and she passed away earlier this year at age 66. It was a long journey, but from the outset, we were determined to keep life as normal as possible, and most importantly, because it was what Winnie wanted, to keep Winnie at home with us for as long as possible. Dementia robs the individual of the ability to communicate their desires, needs, and discomforts. And doing the best for Winnie was very much a team effort from very early on in the journey. There were many organisations that helped us through that journey, but the Derbyshire Palliative Care team was certainly the most significant. The team was involved early enough that there was time for them to get to know us and develop a strong level of trust. And that became increasingly important over the following year or so. And the coordination that team provided across the many NHS services was so significant in helping us. They helped us with changes to mobility needs, assistance with ongoing changes to medication, coordinating with other services, the GPs and the occupational therapists. And they helped us create the right forms and paperwork, respect forms and so on, and emergency packs. So we were ready for the inevitable. Excuse me, sorry. We always understood there'd be an end to this journey, but in the end, nothing can prepare you for those final days. The dementia team helped us feel that we were not on our own, that we could do the best for Winnie and keep her as comfortable as possible. They were able to recognise when we couldn't, when Winnie was in her final days. And they told us with care and compassion the things that we needed to know about the final moments, the things that we'd tried not to think about for so long. Winnie passed away peacefully at home with her children and myself by her side. And we'll always be so grateful to the dementia team for the help they gave us. Thank you.
Thank you, Tim. It's so powerful, and I think everybody really agrees hearing it, how the impact from a family and from Tim of the service and the support from the Dementia Palliative Care team to ensure Winnie was at home where she should have been, Tim, but thank you. Have the next slide, please, Dom. So after a presentation on a national webinar, we were invited to apply for funding from NHS England. They recognised actually the service that we delivered and started to build within Derbyshire was quite unique nationally. So we had funding to develop a gold standard model of our service, a gold standard model that could be shared. It could be implemented within other areas to ensure equity across nationally. So we wanted to ensure we could demonstrate positive patient and carer outcomes. So we captured qualitative data, quantitative data. We needed to demonstrate actually the value financially on a system. And we needed something that could be shared. So on April the 19th, and Tim helped launch the toolkit. It was launched. It is hosted on our website, and it is a comprehensive online document, a flip book with summary of sections and really comprehensive documents you can click into. It's around 127 pages at last count, but it's got 7 sections through business cases, job descriptions, training packages, all the clinical tools that we've developed or worked with universities to pilot. There's all the evidence, there's all the quantitative data, or the data, the financial data. There's everything, absolutely everything a service or an ICB would need to have a look at to be able to start to implement the service within their own system. So as mentioned, that was launched in April this year. And it was all the data that we captured. We had 10 different outcome measures, from monitoring length of stay in hospitals, monitoring readmissions, looking at workforce competence and confidence, clinical outcomes, improved experience, just a whole host of different range of quantitative data. But just to give you a little snapshot, we measured against 3 other cohorts, so we needed to measure against something. So cohort 1 was everybody diagnosed with dementia, cohort 2 was everybody on the dementia register, and cohort 3, believed to be the closest match cohort, was everybody on the dementia register and the palliative care register, so thought to be the most closest match to the patients that we supported. And we captured data from our service of 346 patients. And what the data showed us was healthcare usage post first contact with our team fell significantly. There was an overall reduction in healthcare usage, for example, 111, A&E, non-elective admissions, outpatients appointments, and they fell by about 32%. Our cohort experienced greater reduction in that activity that I've mentioned, but also in cost. There was a cost reduction of 43.4% across each of those healthcare areas. And there was a clear, significant difference between our cohort and the closest matched. For example, in non-elective admissions, the closest matched cohort had a reduction of 11.2% versus our reduction of 43.4%. So all of that quantitative data is within the toolkit that is online there. But for me, most importantly, it was all about the difference it made to patients and families. We did a range of questionnaires with current patients, patients we supported previously, professionals that had contact with their service. There were 7 different questionnaires. And we also did a whole range of semi-structured interviews that we could then do a thematic analysis and learn from. And the themes coming from that analysis, absolutely, the biggest theme was sharing that carer burden. Like Tim mentioned, it was knowing that there was somebody there to talk to, somebody there. They always used to say to me, that actually listened and then did something. It was the kindness, it was the bringing together of the specialism of palliative care and dementia care under that same umbrella. Next slide, please. So on 15th of June was a significant moment for us. Lord Nigel Crisp actually took a question that is on the screen there to have a debate in the House of Lords. The question was to ask His Majesty's Government what plans do they have to expand the use of the dementia palliative care team in England in accordance with our model that we created within Derbyshire. It was about a 12-minute debate, and I have to admit, sat listening to it, I had tissue in hand to mop the tears away because it was just outstanding. It was so positive. And hopefully, Dom, there will be 2 videos that should appear on the screen.
My Lords, I beg leave to ask the question standing in my name on the order paper, and I declare a personal interest as I have a relative who is cared for by the Derbyshire Palliative Care Team, which is as described in the question.
The Derbyshire model is recognised as an example of best practice. The Derbyshire Palliative Care Service Toolkit has been widely shared by the NHS England, which encourages regions to adopt good practice. Resources from the toolkit have also been published on the Future NHS platform. It is a superb example of how better integration of the excellent services already available, not always requiring more funding, can have a positive impact on communities. I thank the Noble Lord. I too have an auntie actually in care in Derbyshire with dementia, and so he's absolutely correct. It is a perfect example of a wraparound service which takes into all the facilities that they need. So absolutely, the intention is that we want to spread that everywhere. It is the responsibility of each individual ICB to set the right commissions in their own local area, but we are spreading the dementia model as far as we can and knowledge of it. Big example actually is that we actually promoted it at the recent National Clinical Excellence Celebration Day in the Midlands.
So, as you can see, a very positive debate, but one reliant on ICBs to take it forward. We have had 44,000 visits to the toolkit, and not just only in the UK, but from a whole range of countries, from the United States, Italy, New Zealand, Australia. Like I've mentioned before, I'm just waiting to visit all these countries, which would be lovely. But it's so pleasing to hear the interest. And I think every week I'm having conversations and meetings with other ICBs, how they can take this forward. But I think we should be proud of what we've done, and we're leading the way within Derbyshire. So thank you.
Gemma, I think you'll see lots and lots of clapping hands there. I think, like me, many of you might be a little bit emotional at this point. The impact of your team, Gemma, is absolutely clear, but it is just those few words of being there that is such a good example. Tim, I'd like to say a very big thank you on behalf of all of us for being here this afternoon and sharing yours and Winnie's story. It must be very difficult, but we're really grateful for you to be here.
You're very welcome. Thank you.
Thank you. We're fast getting towards the time for a break. I'm sure you would agree that every one of the projects and the services that we've heard about this afternoon are all fantastic examples of how we're delivering our priorities. And I'd like to thank everybody involved in terms of delivery this afternoon, but in terms of the services themselves. We're into a question and answer. We are a little bit behind time, but if there are, please do not feel that you can't ask questions. Neil.
Thank you, Julie. I want to go back to the presentation on sexual health services. Derby City is now fast becoming a university city. And I wondered what work is being done with visiting students in ensuring safe sexual relations across the community in Derby City and surrounding areas.
Thanks, Neil. Rebecca, you there?
Yes, I'm here. We work very closely with the universities. We engage from the arrival with students, so we're part of Freshers Week and go along to the universities, and you saw the outreach bus. We go out and have conversations and links with the new student population that are arriving. And we also work out in the community on an ongoing basis. So our work generally tends to be through outreach. However, there are clinics that are open to that population in Derby as well, and information is shared at the universities and colleges in relation to the services that we offer.
Thank you.
Thanks, oh, and Helen, one of my teams in the chat, the person who actually produced the video, she's saying we visit the student halls of residence as well. Thank you, Helen.
Thanks, Helen. Any other questions? I think people have been stunned into silence because there were just some terrific presentations this afternoon around those areas of work. Okay, we are now at a time of taking a 10 minutes comfort break if we can. If you could turn your mics off during that time, and we will be back at 2 o'clock. 2:05, sorry, 2:05. I think we should be back. Sorry, Rob, can I ask Rob, what time are we?
2:05 is fine.
Yeah, 2:05. Okay. If we can be back at 2:05, that would be great. Thank you.
I think we should have music when we're on our break. I hate silence. Don't you feel the need to fill it?
Sort that next year, Kay, no problem.
Thank you, Bob. Just a little one, you know, like that one they used to have. Do 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 do. Something like that. Be nice. And then when it stops, everybody know to start, wouldn't they?
Hey, as Lisa Barrett always tells me, you have to be able to sit comfortably in the silence.
Yeah, yeah. I've got to 64 and it's not happening.
Okay, so we are back from our comfort break, and I'm going to lose no more time and hand you over to Tracy Allen.
Thanks very much, Julie. I'm Tracy Allen. I'm the Chief Executive of DCHS. Very proud, like Julie, to be part of this organisation. And we're going to move into the more formal part of the afternoon. I think that the fantastic presentations that we've enjoyed already have set the context really well, and you'll see a lot of the themes from those 4 presentations picked up in our report on 2022-23. Now I'm working from home today and juggling a suboptimal screen configuration here, so bear with, but hopefully this is going to work to plan. So can I have the next slide then, please, Dom? Thanks. You can see here we've had what we believe is a challenging but really successful year in 22-23. It was our 12th year as an NHS trust. And although much of society during that year was feeling very definitely post-pandemic, you know, the lockdowns were over, the impact of COVID vaccinations meant that less people were seriously ill with COVID. It was actually the 4th year that we grappled with managing the fallout of the COVID pandemic. Many of you will remember that the year included 2 major COVID waves, early last summer, I think it was June, we actually had hit the peak number of colleagues across DCHS off work. It matched the levels of sickness absence due to COVID that we'd had right back in 2020 for a brief period. And then, of course, in January, we had COVID and flu combining into what was a really extremely challenging couple of months for the whole health and care system. So it's felt post-pandemic in many ways, but last year was certainly not post-pandemic for us and other parts of the NHS. And what we continued to see last year was that along with COVID backlogs, we had worsening health inequalities. COVID itself had worsened health inequalities, and the cost of living crisis has continued to worsen those. So we've seen demand continue to grow for many of our services, as the presenters earlier highlighted. And not only has demand grown, but it's led to people presenting with more complex problems. Delays and pressures elsewhere in the NHS have also meant that a lot of my colleagues in the community have been holding people and supporting them for much longer than they would have liked to or wanted to have to do, while those patients waited for other services that they needed. So 2022 was really tough for colleagues managing all of this demand and pressure, being hit, of course, themselves with the cost of living crisis, and in some cases, for very understandable reasons, taking the decision to strike around their pay and conditions. It was a really tough year, and I think it's important that we commend absolutely everybody. It's huge credit to the way in which colleagues right across the Trust have managed those pressures. So that we can report to you that we made great progress on all of our operational priorities during 22-23, that I outlined them this time last year at the annual general meeting. And I think one of the reasons why we've been able to make that progress is that alongside the priorities for communities in Derby and Derbyshire and the provision of health services that they need, we've constantly focused on working equally hard to support our own colleagues in DCHS with their health and wellbeing, and you'll hear more about that in a little while. And finally, financially, we balanced in 22-23, although this required us to take much more, many more one-off measures, non-recurrent measures, to achieve that balance than we've ever relied on before. And I think that's an indication of just how hard making recurrent efficiencies year on year is becoming, something that we are grappling with this year. And I think Pete will say more about that in his section coming up. So you'll be very aware that we've been working in partnership as part of Joined Up Care Derbyshire for some years, but our partnership was formally established as an integrated care system last July with the creation of the NHS Derby and Derbyshire Integrated Commissioning Board. That's the health body responsible for planning and commissioning local services. And also a new partnership, an integrated care partnership between the NHS and Derby and Derbyshire councils. So we've had quite a lot of structural change to work with during the year. As part of those changes, DCHS formally joined together with the other NHS trusts in the system to form what we call a provider collaborative. And we're working together there on things that we can do better together than we can separately. Julie already mentioned the work that we're doing through the collaborative on establishing community diagnostic centres in a number of places across Derby and Derbyshire. One's already opened, as you saw, at the Whitworth Hospital. That's something that we've been doing through the collaborative. We're also working on the recruitment and retention of staff together so that we can make Derby and Derbyshire the most attractive place to come and have a career in the health and care system, and actually stop kind of robbing Peter to pay Paul and the churn of staff moving around between the different organisations. Have a consistent way of making this the most attractive place to come and work, and support people in a managed way to have a career that spans different NHS trusts, different parts of the system, but always focused in Derby and Derbyshire. And then we're also important members of 2 new place partnerships, one in Derby, one in Derbyshire, where we work with the local authorities, with general practitioners, the other parts of the NHS and the voluntary sector to join up and improve health and care. And Rebecca talked about the Sexual Health Alliance and how our integrated sexual health services are working with primary care networks, GP practices, with groups in the voluntary sector. That's all part of that place-based working, as is Team Up Derbyshire, where our community services, local authority care services and general practitioners are teaming up to make sure that we can wrap personalised services around people in the way that Gemma and the dementia palliative care team have done, around people, largely older people or people with additional needs, to keep them support them better at home, manage escalations in their conditions and avoid admission to hospital. So those structural changes are beginning to make a real difference to local citizens. Joined up care requires joined up information though, and last year we really began to see the Derbyshire Shared Care Record making a difference. This is a system that links information from all the different parts of the NHS and the local authorities, so that professionals and clinicians can see the whole picture about somebody that they're supporting wherever they are in their care journey. And it was really great last year to see that DCHS colleagues were leading the way as the biggest users of that system. Next slide, please, Dom. I said we made great progress on the priorities we set for 22-23, and my exec colleagues are going to talk about those in more detail. So just a few headlines really. We're nothing without the fantastic people who work in DCHS. So the first of our priorities in 22-23 was about delivering our plan, recruiting the right people, providing them with the support and development that they needed, and making sure that they were happy, engaged, listened to and involved in the way in which they were working in DCHS. And we made really great strides last year, particularly around recruitment and some sticky areas where we have increased the number of clinicians, in particular in some really hard to recruit areas, working in the trust. We play a really big part in the delivery of urgent care across our system. Our urgent treatment centres dealt with a 20% increase in attendances during 22-23, and that's continued to grow this year. So really significant part of the system's urgent care. And our community teams, that therapists and nurses organised into an urgent care response in the community, managed to see more than 80% of the people referred to them within a 2-hour window. Again, really important for getting the right services into somebody's home to support them without the need to go to hospital or get stuck there. Lisa talked brilliantly about the unacceptably long waits that we're suffering right across the NHS as a result of COVID. And just one example within speech and language therapy of transformation work, improvement work that's reduced those waiting times. And we've seen that right across most of our services. But you will see if you go on to read our annual report and our quality account on the website, we still have lots of people waiting unacceptably long times for our services in the community, and that remains a priority in 23-24. The focus that we had last year on prevention and population health has come out really strongly, I think, in the presentations, particularly again in the sexual health one, where you can see that focus on reducing health inequalities, working with different parts of our communities to overcome barriers to access and to make sure that we can support people with whatever their needs to achieve the same high quality outcomes and improve their health and well-being. And I think all four of the presentations earlier gave examples of how we've transformed digitally, virtual appointments, online access to information, booking appointments, getting STI testing kits, etc. Again, a huge part of our transformation and being focused on the future in line with our strategy last year that continues this year. Julie opened by talking about the horrific crimes committed by Lucy Letby at the Countess of Chester. So I think it's really important that we emphasise here that we're working on all of these priorities to make a difference to health and well-being of citizens in Derby and Derbyshire. And we're doing that by being relentlessly focused on the culture that we have within this organisation. We are absolutely committed to securing the safety of our services and improving them. And we believe that that starts and ends with a culture where everybody in the organisation feels valued and supported. Everybody feels safe to raise concerns and to not fear retribution for doing so, and to have confidence that their concerns will be listened to and acted on if necessary. That's not the only thing that we need to have in place to make sure that our service is safe. We need good information, we need good processes to review that information, good ways of triangulating patient experience and outcomes. And you can read much more about all of that work in the quality account that's there on the slide. But we did just want to highlight the emphasis that we put on a positive culture and making sure that people feel able to speak up. And Darren will talk about that in a little bit more detail. Going to hand over to Michelle in a second, but if we just have one final slide then, Dom, thank you. So I think you've got the sense of real progress over the last, during 22-23, despite those really big challenges. We're going to hear from Darren about the workforce challenge, and I think that still remains probably our biggest risk within DCHS and across Joined Up Care Derbyshire to tackle. So it's great to see the progress we made in 22-23. And I did also just want to flag that industrial action context. Colleagues within the Trust, members of the Royal College of Nursing, took the decision to take strike action in 22-23. Their dispute with the government has now been resolved, and so DCHS is not directly impacted this year, 23-24, with industrial action, but we are supporting other parts of the health and care system who are still managing that really, really difficult situation, and the impact that that has on patients and how quickly they can access care is huge. And then finally, Dom, my opportunity to thank everybody. I found those 4 videos and presentations really, really moving. I am inspired every day by the amazing people that I work with across DCHS. And so I wanted to take this opportunity to thank you all, every member of Team DCHS on behalf of the board, for the contribution that you made to our success in 22-23, and a particular thanks to the wonderful exec team for their energy and commitment in the last year supporting me, especially the 2 new members of the team who joined us last year, Dean Wallace and Pete Hanford. Thanks very much. I'm going to hand straight on to Michelle. We'll go through the rest of the formal presentations and then we'll take a pause for some questions. So over to you, Michelle.
Thank you, Tracy, and hello, colleagues. So my name is Michelle Bateman. I am the Exec Director of Nursing HPs and Quality, the proud Exec Director of Nursing HP and Quality for DCHS. So Dom, if I might ask, can you go on to the next slide? And in a few minutes, can you just seamlessly move on to the next slide? Because my narrative is just going to pick up a few bits contained on the 2 slides. So in 2022-23, as you can already see, our staff continued to raise the standards in quality and patient safety. Each year, regardless of the challenges faced by the NHS, our staff continue to strive to provide quality-driven, safe services. Not only that, but we have continued to explore how we improve the way these services are provided and how we learn from others. We are quite humble, and it doesn't take much for us to go out and look at how other organisations are providing their services and what we can learn. You can read about our achievements in the 22-23 quality account, which has been referred to previously, but I'd like to just highlight some key areas across each of the quality domains. During the year, we had no never events, and these are serious incidents that are avoidable. We maintain a strong oversight on infection prevention and control, with minimal outbreaks, which included COVID and health-associated infections, for example, MRSA and C. difficile. We were compliant with the requirement to report all incidents through the National Reporting and Learning System, known as NRLS. And we've embedded a strong patient safety culture, which is evidenced by incident reporting numbers. And the majority of these incidents are either minor or no harm. And it's really good in particular to see the no harm, because it means our staff will come forward where there are near misses. And we can always learn from incidents that don't actually happen but could have happened. We've maintained our CQC outstanding status. The CQC has not taken any enforcement action against DCHS during the period 22-23. And we have not participated in any special reviews or investigations during that time. Within DCHS, we do have 4 GP practices. 3 of these were inspected during 2016, and each was rated good overall. And in August 2022, St Lawrence Road Surgery was inspected by the CQC and rated good. We achieved full compliance with the Information Governance Toolkit. DCHS was an early adopter of the National Patient Safety Incident Response Framework, and our patient safety specialist has proactively supported embedding this new approach so we can ensure that we learn from serious incidents which may take place across the organisation. Over this year, we are considering how we engage lay patient safety partners into our arrangements. We do expect all of our staff will always be open and honest with patients and families they care for. And this is particularly important when the care doesn't go as planned and where serious harm has occurred. During the reporting period of 22-23, there were 32 incidents meeting the duty of candour criteria. And during this time, patients or relevant other persons were contacted with a full explanation provided following each investigation. For clinical effectiveness, as has been highlighted, we continue to embed our quality improvement approach across the organisation, using the recognised QSA, which is the Quality Service Improvement Redesign approach. And we now have a number of QSA practitioners across DCHS. What this approach does is give colleagues the tools and techniques to embed improvements in the provision of care and treatment. Our internal quality assurance process, Quality Always, continues to develop to reflect the changing environment, and is supported by over 1,200 fantastic quality and safe care champions from various roles across DCHS. The Quality Always approach is really important as it helps to ensure the safety and quality of our services, as it is based on CQC methodologies. During 23-24, we will be launching our We Care peer review process, which will be supporting the teams to be self-governing, as a lot of our teams now are reaching their Gold Award and their Gold accreditation. I'm really proud that we're supporting our nurses to apply to become Queen's Nurses. And Queen's Nurses are colleagues who have been recognised as promoting the highest standards of nursing care within the community. Our numbers now total over 40. And these colleagues will be supported to drive quality improvement across the organisation. We participated in all the national audits which were appropriate for our services, and we continue to actively recruit patients to participate in research, more than doubling the numbers of recruits from the previous year. 53.5% of our staff received the COVID vaccine and 64.5% frontline staff received the flu vaccine. And for the third year running, we participated in the UNICEF pledge to vaccinate 3 children for every member of staff who received the flu immunisation. We are actively preparing for the 22-23 programme and hope to increase these numbers even further, as this will help to ensure our patients as well as our staff are safeguarded against these infections. For patient experience, we are proud that during the last year, 92.4% of service users who responded recommended DCHS as a place to receive treatment. We committed to implementing the triangle of care within our older people mental health services by the end of March this year, encouraging better involvement of carers and families in the care planning and treatment of people with mental ill health, and we achieved this. And during the year, we'll be rolling this programme across all of our inpatient areas. We maintained our commitment to respond to all complaints within 25 days. During the year, we also began to focus on the experience of patients who, due to service pressures, are having to wait, and we've heard about that in the previous presentations. And we're embedding a process of assessing clinical harm whilst people are waiting to be seen. And this work will continue to be built upon in the coming year. We're also now trying to understand the experiences of our patients through a health inequality lens. Which patients are not accessing our services, and how do we work with them to shape the service they actually need? And again, this work will be taken forward over 23 and 24. Having set up these, our priorities for 23-24 are, we will be looking at we're aiming to have 25% of DCHS patients who are discharged from our inpatient facilities to be referred into the discharge medicine services. This is really important so that we can ensure that patients, when discharged, have the right medicines prescribed for them. We will continue to see the experience of our patients who become participants within research studies. And we know that from our family and friends feedback, that our citizens are not always aware of how to raise a concern or a complaint. And we are working hard to make sure that we achieve an 80% for this area. I'm now happy to introduce Kay to offer some words. Thank you.
Thanks, Michelle, and thank you for all you do. My name's Kay Fawcett. I'm the Non-Executive Director who chairs the Quality Services Committee and works alongside Michelle in terms of continuing to support our wonderful trust in achieving its outstanding status in terms of quality and safety for patient care. As the chair of the Quality Services Committee, I, along with some other NED colleagues and the executives and their teams, have got the opportunity to review data associated with quality and safety that comes from the 9 subgroups which provide assurance on all of the topics that Michelle has mentioned in her report. It's our role to assure ourselves about the work being done to ensure that safe patient care and safety for our staff is paramount and at the forefront whilst care is being delivered. QSC looks at quality in 2 specific ways, and Michelle has talked a lot about the data that's associated with that, but the full committee looks at assurance through a series of different lenses, including reports on the key parts of quality and safety agenda, and uses patient and service stories to bring these to life. And this year we heard, just like you heard today, about roles and challenges associated with specific services, and we particularly focused on those in our community nursing services where there have been challenging issues associated with staffing and the access and needs for young people in the LGBT plus community. We've had significant work completed on the waiting list and service pressures that have dominated the headlines for the whole of the NHS since the end of COVID. And we've heard how DCHS are working to maintain safety despite the challenges with those waiting times and despite the fact that people are having to wait longer. We've had much of the work brought to life through a quality dashboard which drills down into the actual care delivered by the teams across the whole DCHS, looking at key components of care, incidents associated with care delivery such as falls and needle stick injuries, and learning how the trust is dealing with them. we can see trend data on a regular basis so that we know that things are improving and we know where the challenges are associated with getting those improvements to work. The second part of the Quality Services Committee's work is to look at all of the risks on the Trust Risk Register across the whole spectrum of its services, and we review these risks on a quarterly basis, ensuring that they're closed or mitigated in a timely manner to make sure that they're reduced to as low as possible whilst we deal with any issues that are raised. We also know that that means that we keep our risks live and we keep people familiar with those risks, and we as the non-executive directors can be assured that that work is going on and that the resources are being put into the right areas to help us to deliver a safe service. I'm not going to say very much more except to say that quality and safety within DCHS is at the forefront for all of the staff within the Trust. And I believe that the work that's been done here and the work that Michelle has talked to you about demonstrates the safety culture within this outstanding Trust. Thank you.
Thanks, Kay. So I'm going to move us on and introduce Darren Tidmarsh, who's our Deputy Chief Exec and Chief People Officer. Is going to talk about quality people progress in 22-23. Thanks, Darren.
Thanks, Tracy. Good afternoon, everybody. Darren Tidmarsh, Chief People Officer and Deputy Chief Exec. Be wrong to start my performance report without a personal thank you to all of our staff and partners for everything that we've achieved in 22-23. I'm going to cover the kind of the people highlights. I'll going to package them in probably three strands really. So one, I'll talk a little bit about our continued focus on health and well-being. I'll then talk about some of the resourcing improvements that we were able to achieve in 22-23, and then I'll finish with a bit about what do staff say about working at DCHS and how we're trying to make this even better. At the end, I'll invite Janet Dawson, non-exec, Trust Vice Chair and Chair of QPC, to give her reflections, and probably particularly on how our plans align and in the context of the recently published National Workforce Plan. So 22-23, as Tracy has outlined, as we came out of the pandemic, we had real kind of societal pressure. And we saw huge rises in inflation, particularly around utilities and fuel prices, and no one is exempt from that. We saw real pressure within all of our staff groups, and in response to that, we packaged together a really comprehensive financial wellbeing support offer, which actually was picked up nationally, both in the Health Service Journal. And we made the kind of the heights of the Guardian at 1.2. We continued to offer enhanced travel rates. We continued with our sit and advice filtered employee grant system for the really difficult situations. We implemented wage stream and salary finance, and a range of other things that were designed to make the pound go further, including financing the NHS Blue Light Card. Our health and wellbeing and inclusion and belonging teams continued to support staff across the Trust, and many staff took advantage of having a conversation with our Resolve service, which is our in-house counselling service, which continued to receive excellent feedback. Just about every single person, over 99%, who had a conversation with Resolve reported that it had a positive impact. We continued to place real importance on keeping everybody informed about what was happening within the Trust. And I think, whilst I'm on the topic of the communications team, I'd like to thank them for the role in organising today's event and much of the content that's been put together. They play a huge role in supporting staff and the public and partners to understand what's going on across the Trust, use multi-channel communication, effective campaigns, event planning and much more. And they're really good about shouting out about other team successes. So I thought it's important to give them a special mention today. We approved a new policy to deal with violence and aggression, and more recently, Julie as chair signed the Zero Acceptance campaign with the police. We also continue to champion a culture of speaking up, and both Julie and Tracy have referenced the Letby inquiry and how this will never be more important at this time. And again, just reiterating that October will be Speaking Up month. In the National Staff Survey, staff told us that they think that health and well-being of our staff is important to the Trust, and we've placed third in the large business category in the Times Britain's Healthiest Workplace. And what was really important about that was it wasn't just about a submission, but they asked our staff about what they thought about working at DCHS. And then recently we've completed wellbeing and lifestyle assessments, which will tell us about how we can support the health and well-being of staff even better into 23-24. During 22 and 23, we did really well in delivering our workforce plan. We recruited higher substantive staff numbers than we've done for a long time, and we reduced our turnover to one of the lowest in the sector. We reduced early career turnover, which remains a focus for 23-24, with work on continuing professional development, flexible working and onboarding improvements. We had the highest number of apprentices that we've ever had in the Trust, with nearly 200 in training and completing their training in 22-23, with new standards including procurement and supply assistant at level 3, associate project manager, public relations and communications assistant and data analyst at level 4, speech and language therapy and enhanced clinical practitioner at level 6, and advanced clinical practitioner and systems thinking practitioners at level 7. You can see that we have the full range of new standards. Apprenticeships will remain in focus in 23-24. We supported 11 young people into employment, 8 within DCHS through the Prince's Trust programme as part of our own organisation responsibilities. We increased our number of trainee nursing associates, and 13 of our previous TNAs became registered nurses during 22-23. We had our first MSc nursing apprentice qualify. We trained 8 health visitors, and 10 district nurses also qualified during this period, and have been sharing our newly qualifying nurse rotation model nationally, which will be expanded to school nursing this year. A huge well done to all of those. However, it would not be right to recognise that in some teams we remain fragile around workforce, and this remains a focus for 23-24, with some further investment planned for the last 6 months of 23-24. On to culture. We took a decision to hear a really difficult story at QPC about the experience of one of our staff who'd experienced discrimination over a period of time. This led to a number of actions around calling out discrimination. We've seen improvements in our performance in both Res and with Des, but there's still much more to do in 23-24. In 22-23, our staff networks came into their own, taking responsibility for each of their specific agendas and working together to sustain an inclusive culture. Together, they arranged and delivered the first in-person networks conference at the back end of 22-23, where we heard some brave but difficult individual stories. We will continue during 23 and 24 to nurture our inclusive culture with a programme around kind and compassionate leadership. And finally, I would like to finish on reporting the results of the National Staff Survey for 22-23, where our staff told us what it's like to work at DCHS, with sector-leading scores in morale and engagement, and the people promise we each have a voice that counts. This also remains a priority for 23-24, and we will share plans for a refreshed staff forum shortly. And 75% of staff would recommend DCHS as a place to work, which is made possible by all of you. Once again, thank you for everything that you do for our patients and each other, and I'll now hand over to Janet.
Thanks very much, Darren. I'm Janet Dawson. I'm chair of the Quality People Committee and have the pleasure of working with Darren and his team on all aspects of the workforce at DCHS. So as you've heard, this year has had its challenges for our staff and our leadership against a backdrop of continued service pressures across the system. Despite this, we've worked hard in a wide range of areas to make DCHS a great place to work, and we really put the needs of our people front and centre, both in their work and their home lives. We work especially hard to create a culture where everyone can thrive and can enjoy coming to work every day. As Darren mentioned, the NHS Workforce Plan was announced this year with the focus areas of retrain, retain and reform. We are pleased to say that we're already doing many things in a number of areas that support these ambitions, and everything Darren has talked about today would fit into one of those categories. I'd like to mention some examples that support each of those headings. Under retrain, we've got our apprenticeships and trainee nursing associates and our work with the Prince's Trust. Under retain, we can pride ourselves that our turnover is down 2% on the previous year and with the highest ranked community trust as a recommended place to work. And we've done a lot around financial well-being for our people. Reform, flexible working and flexible careers. Darren mentioned the newly qualified nurses rotation across the system and our wider talent management. That's a tiny snapshot of lots of things that are going on, which I hope help to demonstrate how we are aligned with the wider NHS Workforce Plan. There's lots more to do, but there always is, but we can be assured that the people agenda at DCHS is given a high priority and is given high energy, and we can look forward to more of the same in the coming year. Thank you very much.
Thanks, Janet. Okay, so we're going to move on now, and I'd like to introduce Pete Hanford, who is our Chief Finance Officer and the newest member of the DCHS executive team. Over to you, Pete.
Thanks, Tracy. I mean, first off, I'd just like to say what a great place it is to work. I've worked in local authorities for a number of years, and DCHS really is a great place to work. And I can't take any credit for most of the things that I'll talk about in the next couple of slides because I wasn't here for most of the year, but there's been some absolutely fabulous things that the team have done to enable the rest of the business to be able to deliver on all the key things that you've heard so far as part of the two previous presentations and Tracy's as well. If you could just move on, Dom, please, to the first slide. I think the important thing to stress to start with is that, yes, we did meet all our financial obligations. That's a really good place to start. It led to the external auditors being really happy with us and giving our accounts a good stamp of approval in terms of a going concern basis, and also on our ability to deliver systems that will achieve value for money for the organisation. So that's a really, really good starting point, as is the fact that we managed to deliver all our efficiency savings that we needed to. Slight downside on that is that only half of it was of a recurrent nature, i.e. it moved itself into saving money in the following year, and that's a challenge that us as an organisation and the NHS generally has got to try and do a little bit better at as we move on into the medium term. We delivered on our surplus, as I said, which is a really good place to be, and that included us making an enhanced contribution towards the challenges that were there in the system as a whole. So we stepped up as we went through the year as an organisation when NHSE was looking at the way that the Derbyshire system as a whole was performing financially, gave us new targets for what they expect us to achieve, and we did our bit to try and help the system achieve its overall targets and aims. So that was a really good example of the sort of system working that DCHS does to try and encourage good outcomes across the whole of the NHS in Derbyshire. On a note of thanks as well, I mean, before I started, the finance team implemented a new financial system, and having done that in a previous organisation, I know what a big job it is now, difficult a task it can be, but it went very, very smoothly. There were some teething problems to start with, as you'd expect, but generally speaking, went very, very smoothly. It did have a bit of a knock-on into our ability to pay our invoices as quickly as we would have liked, in that we didn't achieve our 95% target for better payment practice, but we got to 90%, and we're doing work to ensure that we can get up to that 95% now. So we're changing things, making things work better, and we'll get there. It's also good that we were compliant with all our national targets, but what we do know is that 22-23 was challenging, but we got there. 23-24 is even more challenging, and I'll talk about that perhaps as we get towards the end of the presentation in a bit more detail, because there's some really good positive stuff that it's important for us to recognise. One of them being that we've been able to invest a significant sum in some of our capital projects. We've been helped out with contributions from some of our partners, such as the League of Friends, Matlock Hospital, and we've been allowed to borrow some money through the Public Dividend Capital, which has done some work on our Wi-Fi security and other enabling works. So that's really good. It's all part of our overall contribution towards transformation and the work that we're trying to do in terms of digitally improving the offering that we've got as an organisation to both our patients and staff to deliver efficiencies and hopefully enable better channels for people to access our services. So we're also looking at the way we can optimise our sites as well. It's really important, I think, post-COVID that we look at the way that our work has changed, and whether the sites that we've got are still fit for purpose, whether they're in the right place, whether there's the continued advantages we can take from different ways of working that have emerged over the past 3 to 4 years and embed them properly into the way that we deliver services moving forward, both for the benefits of patients and staff, but also it should help to save us some money along the way, which is no bad thing with the financial environment we're in at the moment. And there's some significant investments, which if we perhaps just move on to the next slide, please. There's a bit more detail about. So we've got a big building project at Bakewell, which is underway, started in July 22. There's some very big structures that are now in place, and we'll be looking for something that will be going live hopefully sometime during 2024. Had a few hold-ups along the way, but it seems to be going pretty well now. We've also got some really great plans for a healthcare hub in Belper. Been waiting for planning permission, but I think we're virtually there now. So again, that's something that we can get on and hopefully get on with the build on that, and that'll deliver improvements in the way that we can deliver services in Belper. Unfortunately, our sort of one sort of downside with regard to some of our building aspirations is that we were unsuccessful in our bid for a new hospital for Buxton as part of the new hospital programme funding, but we weren't alone in that. Many organisations weren't successful, but it's something that we'll keep on the stocks and keep pushing and promoting, something that we feel is really important for that locality up there. On a more positive side, we did spend money on revamping the operating theatres at Ilkeston, and we're also involved in some really good partnership work with UHDB and CRH around community diagnostic centres. The first one appeared at the Whitworth, and that's already been referred to earlier in the presentations, I think by Julie when she was there opening it. But a really good first start in trying to get some of those key services back out in the community where they can best be delivered, so that people don't have to travel into the big acutes to have those sorts of tests done. And we've got more hopefully on the way as we move through the next year, 18 months around the county. At the same time, we're also looking at the way that we deliver our services in terms of our approach to achieving the net zero goal that we've got for the health service, looking at how we can make our plans as green as possible and sustainable as possible. And there are a number of key notable achievements that we had in 22-23 around our renewable electricity, our reduction in carbon emissions, continued maintenance of some of the reduction in business mileage that probably fortuitously came along as we entered into COVID. But we've been able to capture some of those and continue with them, which is really great news. Talked about looking at the buildings, not only looking at what we've got and where they are and how we use them, but also making them more energy efficient. We're not alone in the public sector in having a stock of buildings which is perhaps not quite as new, up to date and modern as we would like in some areas, and by doing the right sort of things with those, we can make them better environments for staff to live in and work in, but also better in terms of their contribution towards our environmental targets. And we're also doing work around electric vehicles and also trying to educate our staff as well in terms of what we're doing. So there's some really great positive stuff that's taking place, all of which will hopefully enable the business to continue to grow and develop in what it wants to achieve over the forthcoming couple of years. I'd be remiss though if I didn't talk about the sort of the downside in amongst that, which is the availability of money to be able to support what we need to be able to achieve. There are targets around efficiency savings that sit both with us and with our partners within the system. They're big numbers that need to be achieved, representing some 4% plus of the total budget that's spent on the health system in Derbyshire. So 150 million overall. Our share of it over 9 million, as Tracy alluded to earlier. These are big numbers, bigger numbers than we've had to find in previous years. Creates a real challenge as we're emerging from COVID, because the pressure was off a little bit during the COVID years in terms of the level and of efficiencies and how we had to make them and our ability to make them. So these are really challenging targets, require a great deal of thought and effort in terms of meaningful transformation programs, so we can make these savings in ways that deliver the best outcomes by hopefully improving patient outcomes while at less cost, but at the very least, you know, we don't make things worse for patients as we're trying to reduce the overall envelope that we've got to be able to work within as far as possible. And also working with our system partners to be able to do that where it makes real good sense to do things across more than one organisation. So it's very challenging, and that's the environment that we're going to be in at least for 23, 24, and as we look forward into later years. Having said all that, I don't want us to get, you know, hung up too much about the savings. They are important. They are something that needs to be delivered. They won't go away. But actually, you know, 95% of what the organisation does is going to continue. We're going to continue to develop and deliver some really important services for local people, and they will continue, and hopefully we'll be able to improve those as we head through the next 18 months or so. And finance and the rest of the QBC committee will continue to enable the rest of the business to achieve those aims, and we'll make the savings as we head along the way. I'd just like to perhaps bring in the chair of our Quality Business Committee, Stuart Proud, perhaps to say a few words just to give his perspective on where we are and what we've done. Thank you.
Thanks, Pete. Thank you very much for that. Hello, everyone. Afternoon. I'm Stuart Proud. I am the chair, as Pete said, of the Quality Business Committee. I've been chair of that committee since April of this year. So thanks to Pete for his summary. It was really helpful. I think I probably should start as well by thanking all the colleagues who support and input to the Quality Business Committee. There are many of them. Will be too many to name here, but without the work that they do, it would make the job that we have to do much harder. So thank you to everyone that does all of the work behind the scenes. I think it would also be remiss of me not to mention and take a moment to record thanks for the previous chair, who oversaw a lot of the work and steered the committee for about 8 years, I think, before he stood down as a NED for the trust in April. So thank you to Ian Litchfield, because he handed the baton on to me and it was a smooth handover. So thank you to Ian for all that he did before I arrived on the scene. So as we heard from Pete, I mean, the Quality Business Committee oversees and assures on behalf of the board a number of key areas of work, which are really vital to supporting the delivery of services for our patients and citizens. Finance and estates is not something that turns everyone on, but they are really important building foundation blocks for everything that we want to do. And so without the strong financial control that Pete has sort of set out, which we've continued to deliver through last year and we continue to deliver into the current year, and the important progress that we've made to improve all of our supporting infrastructure, that includes our estates and our IT, our ability as a trust to provide the services that we do day to day wouldn't be possible. So despite the challenges that we did have, that we faced last year, not just us, I mean, the whole of the NHS kind of were facing similar ones. We did continue to deliver during 22-23. We've heard a lot of that from Pete's summary. I mean, during the course of the year as a committee, we've regularly reviewed and assured ourselves on both the delivery of both our financial and our operational plans. I know Pete and his team really enjoy the fact that every month they come along and have to explain themselves to us, and we try our best to kind of find ways to trip him up and give him a hard time. But generally we always know that we've got a good story to tell in terms of the financial control that we've got in the trust. We've had many regular updates and inputs on our estate plans. As Pete's talked about, we've seen some visible progress this year in terms of some of those. So we're not just talking about big projects, but we're actually seeing big projects come to fruition. And it's been great to sort of see from when I joined the trust, actually now, we have got something rising out of the ground in Bakewell, which will become a great facility for people around that area. So that's fantastic to see. We also, importantly, review progress on our key IT systems. We want to make sure they're safe and secure. We can't function as an organisation without IT. That goes without saying. So it's really important that we satisfy ourselves that those things are working well. We regularly receive reports on that, and it's good to know that we are always on top of the work around that. So thank you to Jim and Alvaro and the team for all they do. As Pete's alluded to about the green agenda, that's been brilliant in that we've continued to do that despite the many pressures that we faced. There are other organisations, I guess, that have probably had to take their focus off this because of other cost of living and other issues, but we continue to drive forward on the green agenda, and it will be important to help us with our financial challenges going forward. I think looking ahead, as Pete's alluded to, we've started the new year well, but the challenges are bigger this time than they have ever been. But we will continue to do the role that we had before, which will monitor our progress as a trust on our both financial and our operational plans, and assure ourselves that we're doing the best we can in terms of transformation opportunities to make a difference. So thank you, Chair.
Thanks, Stuart. Moving along, I'm going to introduce Lynn Walshaw now, who is the lead governor from our Council of Governors, to provide the report from the Council of Governors. Brilliant. Hi, Lynn. Thank you.
Thank you, Tracy. Good afternoon, everybody. I'm Lynn Walshaw and I'm the lead governor for DCHS, and I'm here today representing the Council of Governors to share with you a brief insight into what the Council of Governors is made up of, a little bit of an overview of what we do, and an overview of what we were involved in over 2022-23. So our Council of Governors is made up of 18 public governors who are elected by the sort of local populations across the 5 constituencies of Derbyshire. And we also have one post that is actually representing the rest of England. The reason for having public governors in place is around representing their local communities' views, thoughts, ideas and suggestions to feed that back into the organisation. Our public governors come from a broad range of backgrounds, from industry, education, health, social care, housing, some of whom have retired from employment, but all of whom give up their time voluntarily to the Trust to represent their local communities. We have 10 staff governors, again, elected by the workforce across DCHS, and they represent the 5 main professional groups within the Trust, from estates and facilities, management, administrative support, and clinical staff. And we have 3 appointed governors. Our appointed governors come from some of the key partners that the Trust works closely with. And our current appointed governors come from local governments, from the voluntary sector, and from the University of Derby. So just a little brief overview of what we do as governors. So working on behalf of local communities, representing their thoughts, we bring that public voice to the table, sharing what matters to you, to me, to our families, friends and loved ones. And our staff governors bring that experience, that insight and staff feedback from across the organisation. All of that helps be part of that communication bridge between the Trust and its local communities. And that helps influence what health services could look like going forward. As a Council of Governors, we observe the board and the quality committees, plus many other meetings, and we are in receipt of the Trust's performance reports. We liaise closely with the Executive Board of Directors, the Trust Chair and the non-executive directors, offering support and challenge if needed, and play our part in supporting the Trust to meet its strategic priorities and its statutory responsibilities. Being involved in COG and the many committees that we have access to gives us that insight into where the Trust is around performance, around transformation, and about where risks are managed, all of which gives us that assurance around seeing the evidence is there that the Trust is actually both managing and delivering safe and effective care. As part of our insight visits and reviews, we talk to patients, their relatives, carers, and to staff to hear their experiences of healthcare, what works well and what could be done better. We have a number of other statutory responsibilities as well. We are involved in the appointment of the Chief Executive Officer, the Trust Chair, and non-executive director appointments. They're just a brief overview of some of the sort of key things that as governors we're involved in. But I'm really pleased now to be able to present this next short video This is Jane, who is one of our serving public governors, who is going to share her personal reflection of what being a governor is like. So welcome, Jane.
My name's Jane Dent, and I have been a governor for 3 years. I'm literally just completing my first session as a public governor. For me, it was a way of getting to know the sort of locality, people, and I'd also been in the NHS myself as a nurse for many, many years. I contribute my own experiences in life, my views on where the health service should be aiming, or what are the aspirations of the public, because in the end that's our role, is we're representing, as public governors, we're representing our community. Time commitment can really vary. Again, it's what time you have to sort of give. So I would probably say maximum be 5 hours a month, to be quite frank. It's the insight visits and the gold panel. The gold panel visits are also very, very good ones, where you get to meet a team who are presenting the work that they're doing as part of a process of gaining recognition within the service. And that's very, very interesting. Very, very detailed meetings, but fascinating meetings. It's like any huge organisation, you don't realise the mass of activity and things going on in the background. And as a public governor, that's what you really get literally insight into. It's very, very interesting. I think if somebody has had a broad experience with life, it's useful, because you're trying to represent the broadest spectrum of your own community. So we have a huge range of people of ages and experiences, and every single life experience brings something to the role. Youth can also offer an insight into something, and especially with the mental health issues that the communities are suffering now. There's so many opportunities to involve yourself in all sorts of aspects of the role of a public governor. But say for me, certainly the most revelatory sort of part of it has been the opportunity to meet really very, very diverse members of the community team. Because if you do take the role on and you do want to have a voice, then you have the opportunity of having a voice as a governor. So it really, the governor's role is what you make of it. And it is, I've found fascinating. Daunting to start with, but fascinating.
Thank you, Jane, for that insight. It's really good to always hear someone's lived experiences of being in any role. So this next slide is really just to give a sort of snapshot of some of the things that governors were involved in over 2022-23. As a full council of governors, we met 6 times with an additional 3 extraordinary meetings that were to respond to things that had arisen throughout the year, often to do with things like governor elections, etc., and processes. We held governor elections for public governors, 9 of which public governors, and 5 staff governor posts. And I'm going to cluster a few things together this next part. Participating in 15 Quality Always Gold panels, 3 Dignity Awards and 19 Insight visits was where we got to see amazing teams who on a day-to-day basis are supporting or caring for people wherever they are on their life's journey. We literally laughed and at times were reduced to tears by some of the presentations that we received. Seeing the outstanding efforts that staff put in to ensure best quality care is delivered across the board was absolutely phenomenal. At some of the insight reviews we did with staff, we had opportunity to talk to staff around their aspirations, their hopes, and some of the challenges that they faced within their daily working lives. And we're able to see how the Trust responded to helping those teams find their pathway to actually achieving those aims and aspirations. And it's been a real pleasure, and I have to say a privilege, to be involved in recognising and celebrating the many achievements that the teams have made throughout the year in ensuring high quality care is delivered in the best environments for individual service users. We participated in 8 nationally required patient-led assessments of the care environment reviews, visiting all of the inpatient services that DCHS delivers care from. We participated in 3 complaint review panels, which are independent panels, looking at how the trust actually manages any complaints and concerns. And we are governor representatives in the system around the public participation and partnership groups, of which there were 12 different meetings, all of which look towards how the public is engaged and how communications are actually fed into and out of organisations to help shape what services could look like going forward. We were delighted to contribute to the appointment of our new chair and to 3 of our new executive director appointments. And not to forget our own governors themselves, we participated in 5 governor development sessions, both at national or local levels, helping support our governors in being fully briefed on both national and local initiatives, and at their request, things that they actually identified that would help them fulfil their role effectively throughout the year. And I think you'll see from the slide, there's always plenty to keep us busy as a council of governors, where there's always lots to be involved in. And I think looking at what we've heard of this afternoon around where the trust is at, around its performance, we as governors and the council of governors, we get to see that. And that is a real sort of indicator, I think, of being able to actually see and understand how the trust operates, and to give that assurance, as a council of governors, seeing what we see, being involved in what we're involved in, gives us absolute confidence that care is delivered safely and effectively across DCHS. And the efforts that everyone puts into that is absolutely outstanding. And I just wanted to sort of end really today's sort of presentation to say that we're always really pleased and interested as a council of governors to hear local thoughts, ideas and suggestions, all of which goes towards shaping what local services could offer. So please feel free to get in touch. We really, really look forward to hearing your voices and helping shape what DCHS could look like going forward. So thank you very much for listening.
Thanks, Lynn, and huge thank you on behalf of the board and the whole organisation to you, Jane, via the video, and all our other governors, both public and staff. You bring such a lot of energy, time, insight and challenge to the way in which the organisation works, and you've made a really important and continue to make a really important contribution to our development. We're nearly there, folks. It always seems strange at this point to be talking about the year ahead, which is the year that we're already in, and in NHS terms is almost half over. But Dom, if you move the slides on, I think the formal presentations have actually trailed quite a lot of this in terms of what we're working on. We established ourselves as an integrated care strategy, as I said, last July, and this June we published our first Joined Up Care Derbyshire integrated care strategy. And that's setting out the framework, the key areas of focus for us as a health and care system for this year and the coming 2 or 3 years afterwards. You can see there that the strategy is focused on 3 main life courses. So it's about starting well, and we've got a key area of focus within that on supporting the social, emotional and physical development of children from birth until they start school when they're 5. We've got Stay Well, which is about us in adulthood, and a particular focus there around prevention and early intervention into the 3 main clinical causes of ill health and early death in the Derby and Derbyshire population, which you may be aware of. They're circulatory disease, respiratory disease and cancer. And then around ageing and dying well, we've got a particular focus across the system on enabling older people to live healthy, independent lives at their normal home for as long as possible. Next slide then, please, Dom. So the system's committed to doing some things differently in terms of delivering against that strategy. It's about prioritising prevention and early intervention, tackling those inequalities in outcomes, experience and access, working with people and communities and the strengths that they've got, and developing and delivering really personalised care in partnership with people, and then joining it all of our bits up, connecting better, aligning better, so that people are not ping-ponging around the health and care system, but we've organised ourselves around them in a sustainable way for now and for the future. And I hope, if you move on to the next slide, please, Dom, I hope that what you've seen already this afternoon is that our organisational strategy that Julie introduced, if it matters to you, then it matters to us, which is what the document that sets out how we're going to contribute to that overall integrated care strategy, to the start well, stay well and age and die well. I hope you can see the way in which our priorities in 22-23 really fit into those categories about prevention, early intervention, reducing inequalities, being personalised, working with people on what matters to them, where they're at, and how we can support them. And you can see from what we've all said, what our colleagues said in the first half of the meeting about the work that's actually going on to connect our services up much better for everybody who uses them. So our strategy isn't just a document that's going to sit on a shelf and gather dust. We developed it with people right through the organisation, with partners and with the public. And we're using it every day to guide the decisions that we make, the priorities that we set, to ensure that we're all pulling in the same direction and that we're using our resources to move us closer towards that overall strategy and improving the health and well-being of people right across Derby and Derbyshire. And then if you move on to the next slide, Dom, colleagues Michelle, Darren and Pete have already begun to set out what our operational objectives are for 23-24. I'm not going to list them all here. You can find a summary plan on a page of those priorities on our website, but they absolutely fit in to those system strategic priorities. They're absolutely embedded around being sustainable, focused on the future, healthy communities, people at the centre. And they are a continuation really of some of the things that we've already set out that we progressed in 22-23, reducing waiting lists and backlogs, reducing health inequalities, making sure that people can access urgent and emergency care when they need it, making sure that people are not ping-ponged around services, dropping off when they get admitted and discharged from different services with all the risk that that involves. And at the start and end of all of that, making sure that we've got the workforce that we need to provide those services, and that we've created together a culture where everybody in the organisation is recognised, valued, and able to bring the whole of themselves to work and make their contribution to improving services going forwards. It's going to be really challenging. Pete's talked about the financial challenge. We've already seen about the workforce challenge and the demand challenges. But we're very proud of our achievements over the 12 years we've been an organisation. We're very proud of what we delivered in 22-23. And I think, I hope you've come away this afternoon with a really clear impression that this organisation is built on capable people doing fantastic things every day. We heard some great examples from Rebecca, Pippa, Lisa, and Gemma earlier on, I think we can look forward with optimism and determination that we'll get through 23-24 as successfully as we did last year and continue towards our mission and ambition of providing fantastic local health services and improving the health and wellbeing of people in Derby and Derbyshire into next year and beyond. Thanks, Dom. So I think we're at the end of the formal presentations, very conscious that we've spoken fast and delivered loads of information. We can only ever provide a really high level summary of everything that we did in 22-23. And Rob's been fantastically diligent in the chat of putting in links to the annual report, the quality account, and these presentations where you can find all of that in your own leisure. But we're going to open it up to all of you now. As Julie said at the beginning, this is an important opportunity for you to hold the organisation through the board to account. So we'd be delighted to hear any comments, questions that people may have. Thanks. Or not. Jane, star of the small, large screen, and clearly a very talented artist, which I hadn't appreciated.
Actually, most of that was my son's. That was all sort of subterfuge. Yeah, I was asking would I get royalty for any of for my appearance. Much better than I thought it was going to be. So no, my actual own question is more to Peter and Stuart. I was just wondering, with all the stuff that's been going on with the aerated concrete in schools, have we got any estates that we're concerned about?
I'll bring Jim in, actually, Jane, if Jim's around. Jim, do you, and it's remiss of us not to mention such a topical issue. Jim, do you want to pick up on RAC?
Definitely, although I'd quite like to see Peter have a go at answering it too. So reinforced, aerated, autoclave concrete, much in the news. In 2021, the NHS were alerted to challenges with RAC, as it's called, and we did a comprehensive inspection of all our buildings and properties that we work out of, and there was none found. There was one beam of concern with something slightly different, which was inspected, found to be fine, and we have a kind of 5-year regime on that. Since then, beginning of this year, the notices were issued again, so we've gone around and checked again, and there's now a kind of NHS plan, but DCHS, and in fact pretty much the whole of Derbyshire NHS, actually more broadly than that, is unaffected by RAC.
Excellent, thank you. And thanks, Dom. Anybody else got any questions or comments? Paul.
I've received,
Paul, you're on mute.
I do apologise.
Don't worry.
You can't lip read us. Yeah, I just wanted to sort of focus on how the trust fits in with GP practices and dentists. I appreciate the reports about the trust, but I didn't think there was much in the report on how GPs are, the pressures they're under, how well they're working with local hospitals. I mean, obviously my local hospital is Ripley, and I know my personal experience where my GP wasn't particularly good with Ripley when I was there personally, but I was just wondering how things are, because obviously GPs and dentists are under severe pressure, and I'm just wondering what can be done to help them, or they help the trust, if you see what I mean.
Yeah, it's a great question, Paul. We work really closely with general practices right across Derbyshire, and as you picked up, we actually provide 4 of them ourselves. So we do a whole range of things. The urgent treatment centres that we talked about, and the 20% increase in activity that they had last year, the 16% increase this year, some of that is we're actually filling a gap that general practices can't fill. So providing same day access for minor illness as well as minor injury. We we actually employ, I think it's about 150 staff who we've employed on behalf of GP practices. So that's a range of paramedics, nurses, therapists, etc. We employ them, but they work out in GP practices to enhance the general practice teams. And then our community teams through Team Up, we've organised those around groups of general practices called primary care networks, and we work incredibly closely with those primary care networks, developing services that can support the individual practices and the population in Chesterfield or in the High Peak or in the Dales or around Ripley. So work on a whole range of different things, provide some services with them, provide some services into practices. Don't do much around dental services. There is a separate kind of out of hours dental service that supports high street dentists, but we don't provide that. And you're right, general practice is one of the areas which is under most pressure. Great, I can see John's got a question. Did you want to come in, Rob, with one that's come up in the chat, and then I'll bring John in?
Yeah, it was quite a challenging one actually, about surely that improving quality and reducing spend don't really go hand in hand. So how are we trying to balance that particular issue?
Can I come in on that?
Yeah, I was going to say, Michelle, why don't you pick that up?
Yeah, so I think one of the key components of DCHS is our internal assurance process, the quality always. And using that alongside things like our insight visits, a number of the execs make ourselves known to our teams as well. But what we try and do is empower our teams to look at quality, safety, as well as the financial, the financial and constraints that we have. But fundamentally, the quality always is one of our really strong assurance threads that allows us to make sure that we're keeping an eye on what's happening in terms of quality and safety. But we have other mechanisms as well, Rob. So I think it's generally about we've got the quality and equality impact assessment process. So any decisions that will have a financial consequence, i.e. with transforming, or we're looking at reducing spend, we have to go through a quality and equality impact assessment. And that panel is attended to by myself and the medical director, and we have one of our non-exec directors on that as well. So we're always keeping an eye on what's happening. Thank you.
Just on that, I mean, it is a real challenge. I suppose I wouldn't want to lose the fact that sometimes improving quality and reducing cost are one and the same thing. So, we had I'm thinking, Michelle, about some of the work that the wound care service have done about, when you get the right care being delivered with the right dressings and the right in line with best practice, what we've actually seen is that people's wounds heal more quickly. We use less inappropriate dressings. People come less. So there can be a sweet spot where actually improving quality also reduces cost. To make sure that we never get into trouble, as Michelle said, we've got all those processes where we're looking at ideas to reduce costs and making sure that if they're not improving quality, they're certainly not reducing quality or adding any risk. Julie's already texted me to highlight the fact that I've got people's hands in the wrong orders, John, so you'll have to be a little bit patient with me because we've got Tracy Elder who pipped you to the post. Tracy.
Yes, thank you. I'm one of the new staff governors that Lynn mentioned, and I just wanted to say how wonderful it was to attend the meeting and to see the presentations and to hear from everybody, and how it really opened my eyes to all of the amazing things that we're doing in DCHS. And I'm just so pleased to be part of the new Council of Governors. And I just wanted to say thank you for the opportunity to come and listen to everybody today, because it's just been an amazing experience. So thank you very much.
That's lovely to hear, Tracy, and thank you for standing for election as a governor and for the contribution that you make. Tracy's part of our growing research capability that Michelle touched on, as well as providing great community therapy services. Thanks, Tracy. John, did you want to come in?
Yeah, since it's the annual members meeting, to mention again that the success of the Tea Talk Tech Cafe, which was established nearly 2 years ago now in Ashbourne, in the last 12 months, they've helped over 400 people to understand computers and access such things as doctor's appointments and their own health and well-being. It's that ongoing necessity, you might say, for bringing people on board in this computer age. And since since last year, they have now opened another Tea Talk Tech Cafe in Wirksworth and a second one really in Matlock, replacing the one at Hurst Farm. And without the help of Rural Action Derbyshire that have brought this network across the county, bringing various organisations together, opening up Tea Talk Tech Cafes in village halls across the Derbyshire area, and one in particular I was so pleased to hear about was the one in the West Indian Association complex in Derby, where they have set up that system, and also health and well-being sessions, Otago chair-based exercise, etc., etc. And I think one of the things we should be proud of also is Jim Austin's input into having some provision of iPads for community use, which have been so invaluable for the community. And I think the emphasis again comes back to we are a community service. And I think that's so important to remember in a community environment and where we get the help from and who provides that help. So thank you.
No, thank you, John. Brilliantly put. And, you know, all the examples we've had this afternoon have touched on how important technology is becoming as a way of accessing and providing care. So it's vital that we do work with the community to support everybody in the community to be able to use those digital channels. Jim, very quickly before I hand back to Julie for our concluding remarks.
So really quickly, it's just to say that although I facilitated the iPads, they were from the NHS England national stocks. But it really reinforces our point that some places, the voluntary sector is significantly better placed to interact with communities than we in the NHS are. And I'm a firm believer in that with some of the technology support as well. Thank you.
Thanks, Jim. Julie, I'm going to hand back to you. I can't see any more hands to bring the afternoon to a close.
Thanks very much, Tracy. And I think with those last comments, I think we've sort of come full circle, haven't we? We started with Rebecca talking about the importance of partnership and working together and how we can only do this with others. And that's where we finished this afternoon. So that's a great way of actually demonstrating how important it is to be part of a system with partners. So everybody, I do hope that you found this afternoon both informative but also enjoyable. I'm incredibly proud of being chair of DCHS, and actually I'm really optimistic about the future. I'd like to extend a very big thank you to our Chief Executives Department and the communications team for organising this event this afternoon. It's been brilliant. All of the colleagues who have contributed today, a very special thank you to Dom, who's made it actually tick along really beautifully. I'd also like to say a very big thank you. Everybody's done that during the course of the afternoon, but a massive thank you to Tracy and our executives, all of our non-executive directors and our governors, as Tracy has said, who give up their time as volunteers. But also to all of our colleagues that actually do their utmost every single day to actually support patients within Derby and Derbyshire. The biggest thank you to you. And all of you for actually being present today, for your attendance and contribution. It's been great to spend time with you. And with that, I hope you have a good rest of the afternoon and a good evening. And just to remind you, if you'd like to become a member, then please, as you leave the virtual room this afternoon, take a note of this particular link. Thanks to everybody and good afternoon.